This presentation was recorded at the 12th International Conference on Rapid Response Systems and Medical Emergency Teams.
Thank you very much for this opportunity to talk about what we are not doing, because we haven't implemented such a nice program as Rinaldo would have liked us to, and I would have liked us to as well. So this is where I work. That's the main center for simulation in the capital region of Denmark. I don't have any conflicts of interest to declare here. And this is what I will briefly talk about, that we have diverse teams to respond to deterioration, and they might need, and they absolutely get, diverse training. We conducted a small national survey, which was not very comprehensive, but give you an idea. And then I'll talk about what we still need to do. Well, I will start with the national survey conducted in 2015. It was a very small one, and with some questionnaires, and done by one of our nurses who work with deteriorating patients, the rapid response systems in one of the hospitals. And she identified 35 intensive care units in our country. We are a very small country. And we got answers from only the 25 units. And 17 out of these 25 units or hospitals have rapid response teams. So it's not every hospital in Denmark yet have rapid response teams. They all have cardiac arrest teams, but they don't all have rapid response teams. The team configuration, and I apologize for this black part of this, you can see that the teams, the rapid response teams, are quite different from each other. Some are led by doctors, some are led by nurses, like outreach teams, and a few, that's the dark blue one, is anesthesia nurses. And we define the team as the outgoing team from ICU or anesthesia, together with the ward team, which would be the primary nurse on the ward team for this patient, and a doctor affiliated to this ward. And here you can see how little implemented the rapid response systems are in Denmark, actually. In the light blue columns are number of beds in each hospital. It's the names of the hospitals, which you can't read for the 17 hospitals. And in black, you can see number of med calls per year. And as you see it, lots of hospitals have more beds than calls per year. So it amounts to almost nothing with the rapid response teams. They are not really implemented, as Daryl would say. The dose is not high enough. A few of the hospitals have quite a lot of calls, actually. And those hospitals are the most eager ones to actually try and get the message out. Of course it is. They have dedicated nurses who are advertising for what they are doing, and they are actively doing quite a lot to get more calls. Some of the hospitals are almost actively doing something not to get too many calls, because they are so busy in the ICUs that they simply can't feel that they can't fulfill their obligations as a rapid response team. So what about the education for it? We also asked about that in this survey. Well, not in a very specific manner, but we're asked how many days or hours do you use on education when people are employed in the ICU? How many hours, days do you use for education for them to become part of the rapid response system or rapid response team? And as you see here, it ranges from 0 to 4 days. And that's, well, totally random. There are no really programs in each of the regions. In Denmark, we have 5 healthcare regions, and not even in the region I am in, we have specific programs for this. It's entirely up to each hospital to find out what they think they need or how many resources they will use on it, which is in contrast to exactly what Rinaldo just talked about, because in our region, it's mandatory to have some training, not for all. We don't all go to ALS training, but the ward staffs, the ward doctors go to an intermediate kind of training, and only the leaders of the cardiac arrest teams take on ALS training. But still, it's mandatory for everyone, at least every second year, to have either BLS or intermediate training or ALS training. So, what kind of education? And I know you can't read it, but it doesn't actually matter, because you can see on this plot that it's all over the place what people are being taught on this education for rapid response teams. And, well, part of it was because of poor wording of our questionnaire, I know that. But some of it is that you are introduced specifically to your med function, for the rapid response team function. You are specifically introduced to how to respond and what to do with the patients. But some of it is medical stuff, that you are taught how to deal with septic patients. You are taught how to do an ABCDE of the patients. And some of it is also talking about, they are also answering what are the methods of your training. And some of it is e-learning, some of it is simulation training, and lots of it for the nurses is peer-to-peer training, that you come along on calls and you are taught this way how to respond to the calls and what are your obligations on a call and that sort of thing. What about on the wards? Are they taught how to respond to deteriorating patients or how to use the rapid response system? Well, again, that's very, very varied. Not everybody has any education for this. Some hospitals introduced a one-day training for the critically ill patient or for deteriorating patients. Some hospitals says it's entirely up to yourself here. The blue one up here is, well, if you want to, yes, you can take some training. And this one is that's also entirely your own responsibility, which is kind of funny, because I don't think there's any other training that's entirely up to yourself whether you want to take it or not. So, as you see, it ranges from no training up till 8 hours of training on one day for the ward staff on the deteriorating patients. Supervision, feedback, especially for the nurses. Doctors only get feedback if it was cardiac arrest. Some have 2 to 3 annual theme sessions, brush-up or improvement discussions, but only a couple of hours each time. And some have quite comprehensive bedside training and supervision. And these are also, well, kind of the same, it's also evident that the nurses get more training than the doctors. It's said that, or it's just thought that doctors can do this because they are trained in some other way. They're specialists, so they ought to do this as well. Yeah, and I agree, of course, that if you have different teams, and if you look at the teams or you look at the persons from the wards, of course they need different training. But most of all, I believe that they need to train together, because they are working together around the patient. So this is one of the most important things that you need to train for these rapid response team training, is that you come together as a team and you must act as a team around the patient. I also agree that everybody on the ward, that you should focus the training much more on the deteriorating patients, how to find the patients, how to score the patients. We've introduced the National Early Warning Score, but without much training, just saying to people, now you need to score these people at least twice a day, and then you will find them, and then you have to respond to it. And I think that this needs also to be trained. But for the exact responses, when the team is coming, you need to know how you are going to act as a team. So in one of the hospitals in our region, they did introduce this kind of training. It's a full day of training. It goes through, it's for the ICU doctors and nurses together with the ward staff. They train together the whole day. There is some theory, small theory, about deteriorating patients, how to use the early warning score. And then it's about the first 5 minutes. How do you respond on the wards, and how do you then come together as a team and respond to this patient and take care of this patient? It's based on simulations with debriefings. And as I said, it's totally interdisciplinary. It's the whole team. And they also have quite a high utilization of medical emergency teams or rapid response teams on that hospital. So I think these things, of course, they work together, that if you train together, you're just much more likely, you know what you get when you call the team, and you are much more likely to actually activate the team. But what is not trained? Well, decision-making is not trained so much. What about biases in decision-making? Who would benefit from getting to the ICU? It's not even part of the training of the specialists in ICU. Which sequelae do you have after ICU, and who benefits the most from it? And the end-of-life decision-making and conversations. Yesterday we heard such a lot about how big a part of the rapid response calls this is. Why isn't it taught in the curriculum? So what I think we need is really to define the competencies which are needed, and thus the curriculum. I think it's much more easy to define what you need to train in a cardiac arrest situation, because as Rinaldo so beautifully put out, it's quite simple algorithms, and it's quite simple. It's not so complicated what's wrong with the patient when they are in cardiac arrest. But to find them before they are in cardiac arrest and to mend that situation, it's much more complicated. So define the competencies needed on the teams for each of the roles in the team. Train the entire team together, and train the human factors that makes a team become a good team and makes the team able to work together. And I would highly recommend going to the YouTube and see just a routine operation if you think about what she's talking about these human factors and what's the problem with working together and using these things.